I'd like to thank Dr. Brown and Dr. Martin for inviting me to speak today on evidence-based medical management of severe acute pancreatitis. I have no disclosures, and this is a quick overview of the different topics I'm hoping to touch on today and give you some evidence on. The first thing I think is important for us to clarify definitions and make sure that we're all talking about and thinking about the same patients. Today, using the revised Atlanta definitions, we're going to be mostly focusing on patients with severe acute pancreatitis, or the SAP patients, those patients with local or systemic complications and persistent single or multiple organ failure greater than 48 hours. These patients really are the ones, these SAP patients are the ones that kind of go on to develop necrotizing pancreatitis with the ANCs and walled-off necrosis and pseudocysts and all of these, that group of patients. So I'd like to touch on next the early identification of severe acute pancreatitis patients. We all know that they're at risk for developing significant complications, and so early identification really helps guide clinical decision-making and is also very helpful for early triage, either to an intensive care unit in your hospital or a tertiary care transfer. Early identification can also help to select patients for novel prophylactic or therapeutic treatments, like with the activin A inhibitor follistatin, which is currently being looked at in animal trials. And this is it may be kind of fast forward a few years into the future, we can identify an SAP patient in the ED, and then give them an infusion of a drug that might help them to prevent severe development of severe complications. So as far as identifying these patients, there was a very interesting systematic review and meta-analysis done last year from the Dutch Pancreatitis Study Group, looking at the early laboratory biomarkers in their ability to predict severity. The outcomes of the study were those patients that developed moderate, severe, or severe acute pancreatitis, and or patients that developed pancreatic necrosis and organ failure. And the conclusion was that IL-6 at admission at 24 hours is actually superior in predicting the development of SAP in comparison to commonly used markers like serum, C-reactive protein, and the Apache 2 score. And with a sensitivity and specificity of about 90%. So it's pretty accurate. And I know it's going to change my own practice for sure. So let's kind of switch gears a little bit and say that you have a patient with severe gallstone pancreatitis in front of you, and you ask the question, is urgent ERCP going to help improve the outcome of patients? A patient who does not have cholangitis. And this is another study done by out from the Netherlands, also last year. And this was a multi-center randomized controlled superiority trial of conservative treatment or urgent ERCP within 24 hours for predicted severe gallstone pancreatitis. And what they found was that in these patients who did not have cholangitis, urgent ERCP did not reduce the composite endpoint of major complications and mortality compared with the conservative treatment. And so basically, ERCP is only indicated in patients with cholangitis or persistent cholestasis. All right, what about sterile necrosis? So in 1964, Dr. Ken Warren said, the most common errors in the surgical treatment of acute pancreatitis are to intervene too early in the course of the disease and do too much, or in the secondary or septic phase of the disease to intervene too late and do too little. This is absolutely still true today. And so I think it's really important for us to remember that sterile necrosis can be treated conservatively in about 60% of patients without any intervention at all. So looking at this CAT scan, here's a CAT scan with a patient with a sterile walled-off necrosis at 30 days, and the same patient at 6 months without any intervention. And so in this day and age of minimally invasive everything, I think the most minimally invasive option is patients. Pancreatologists treating patients with necrotizing pancreatitis need to know when to support the patient with medical support and when to do nothing. So let's quickly talk about abdominal compartment syndrome, because we do see this periodically in our patients. Abdominal compartment syndrome, defined as a sustained intra-abdominal pressure greater than 20 millimeters of mercury associated with new onset organ failure. And so when you have a patient that develops compartment syndrome, really the primary first line is medical treatment, and it should target a decreasing hollow visceral volume with an NG tube, Foley and a rectal tube, managing intra or extravascular fluid, like maybe putting an IR drain in the ascites, and the use of medical abdominal expansion, or i.e. paralysis. When that doesn't work, and the patient progresses on to a sustained intra-abdominal pressure greater than 25 millimeters of mercury associated with new onset organ failure that's refractory to all of the medical therapies above, then it is indicated to do a decompressive laparotomy, a bilateral subcostal laparotomy, or a subcutaneous linea alba fasciotomy. I think it's really important to point out to really just do that and stay out of the retroperitoneum, and really even everything below the omentum, so as to reduce the risk of infecting the peripancreatic and pancreatic necrosis. Okay, so what about antibiotic prophylaxis? Well, it is not recommended for the prevention of infectious complications. And this is really, there's really pretty strong evidence that's been assessed by several double-blind randomized controlled trials. And prophylactic antibiotics are basically associated with the development of multi-drug resistant bacteria and fungal infection. And so they're really only advised for the treatment of either confirmed or clinically suspected secondary infection, like pneumonia or UTIs, things like that. Selective gut decontamination has been shown some benefits in preventing infection, and actually probiotics are actually contraindicated in this patient population. Okay, so you have your patient who has had sterile necrosis, now develops a new leukocytosis and a fever. And the question is, does my patient now have an infected ANC or a walled-up necrosis? I think we all recognize that clinical suspicion is really the primary driver. Basically, fever, leukocytosis, new onset organ failure. However, during the early phase of severe acute pancreatitis, these parameters are really inaccurate due to kind of overlying SIRS. And so these patients, 33% of patients with severe acute pancreatitis actually have a sterile collection, but extra pancreatic sepsis, like pneumonia or UTIs and things like that. And so a generalized kind of fever workup should always be done first. Once a patient does develop bacteremia, it does increase the risk of your patient developing infected pancreatic necrosis in the future, and should raise that index of suspicion in your mind moving forward. If you see gas on your CT, it's basically diagnostic of infection. However, in 42% of patients with culture-proven infected necrosis, there's gas is present, and in the rest of them, it's not present. And so those patients really do benefit from a percutaneous fine needle aspirate of the necrotic collection. Okay, let's talk a little bit about nutrition. Nutrition is one of the acute Achilles heels in the treatment of SAP patient. So basically inadequate nutritional support. Once a patient has insufficient caloric intake after 72 hours, with SAP, enteral tube feeding is indicated. And necrotizing pancreatitis patients have very high protein calorie needs. Many patients are and because of this, and because of the concomitant SIRS and other things, the space occupying edema and peripancreatic fluid collections, they're unable to meet their daily needs, even if they can tolerate POs. So if you do need to assist with their nutrition, you should be using enteral tube feeding over TPN. There is very strong evidence to support this, many randomized controlled trials demonstrating decreased risk of infections, multi-system organ failure, and even mortality. And whether NG or NJ, either is fine if there's no gastric outlet obstruction and the patient is tolerating it. So finally, let's just touch on important lab trends in these patients. I call them the weekly C labs, and these really help with complex decision making in this patient population. We get them weekly as an inpatient and then during all outpatient visits. And the CBC, the CMP, the Comprehensive Metabolic Panel, the C reactive protein, and a prealbumin. There is no need to follow amylase or lipase in these patients outside of the initial presentation, and it's basically a waste of the patient's money. So in summary, in the medical treatment of severe acute pancreatitis, early identification of SAP patients with IL-6 can help triage patients to a regional tertiary center with a multidisciplinary team. ERCP should only be used for patients with gallstone pancreatitis with cholangitis or cholestasis. We should leave sterile necrosis alone as long as possible and avoid any early interventions at all in the first 1 to 2 weeks. Routine antibiotic prophylaxis is not recommended, and enteral tube feeding over TPN is best way to give supplemental nutrition via either the NG or NJ route. And it's really helpful to trend the weekly C labs to help with complex decision making. Thank you very much, and I look forward to your questions.